Yeah, thank you.
Okay, so welcome Governing Body and members of the public to Barnsley CCG Governing Body meeting in public. First item is housekeeping. We're all in different places, working remotely. You all know what to do and where to go. Apologies, Kay. Do we have any apologies?
We don't have any apologies.
That's good. And are we quorate, Kay?
We are quorate.
Take us to the patient story, please.
Okay, thank you, Chair. It seems hard to believe that in 5 days' time, it will have been 1 year since the very first lockdown due to the COVID-19 pandemic. For most people, the change that happened overnight and changed the way we have been able to live our lives, it has become apparent to me that the easing of the lockdown and moving back into the new normal will be just as hard. Even with the fantastic rollout of the COVID vaccine nationally and the 80,000 vaccinations given to the people of Barnsley, many people, including those who are extremely vulnerable, will worry on the easing of the lockdown. I would like to introduce our patient story, which as always is based on a true patient account. And I would also like to say a huge thank you to Seren for giving her permission for us to share her story.
Thank you.
Thank you. Is Seren on?
Seren is on, Jane.
Sorry?
Seren is on. She's on the call.
Sorry, is that?
Yes, it is you.
Hi.
Hi, Vicky. Thank you.
I'm sorry, I've not done this online. Should I just start with my story?
Yes. Yes, please.
Yes, please.
When lockdown started, everything felt just surreal. Coronavirus had been building for a few weeks, but apart from washing my hands extra vigilantly, I didn't think things would get as bad as they did. Me and my colleagues were gobsmacked when people started hoarding toilet roll. I've got several health conditions that would make me vulnerable, but I didn't realise the full severity of the situation until I started to shield about a week before the official government lockdown. A friend of mine shared on Facebook that over 900 people had died that day alone. I thought she must be mistaken, so I checked. And she was right. And every day the figures just kept going up. I've got a damaged lung, asthma, a compromised immune system and several diseases. I was terrified of catching the virus, but I was one of the lucky ones. I could work from home. I had my boyfriend who is also extremely vulnerable. We had a garden and we'd managed to get food deliveries by the skin of our teeth. As two people who were medically vulnerable, we had to shield, and that brought with it its own physical and mental health implications. However, we soon settled into a rhythm and I started to find comfort in the safety of my home. As the weeks went on, I started to worry that lockdown was going to have to end eventually. I remember watching the rolling headlines on the news of healthcare professionals who were having to choose who would live and who would die because there just weren't enough respirators to go around. And I've got a damaged lung and a rare disease. I knew that if I got the virus at its peak, I probably wouldn't be lucky enough to get one of those few respirators. My depression and anxiety that I've lived with since I was 9 just engulfed me. I was terrified. I never wanted to leave the safety of my bubble. As the weeks went on, my anxiety grew. Last VE day, I saw vast vast conga lines on the news of partygoers as small eases in lockdown began. I saw images of beaches just swamped with tourists, and I understand the need to want to get outdoors, perhaps more so than most, having had to shield. But it's heartbreaking to watch thousands of people just disregard precaution and potentially undo the sacrifice burdened particularly by the clinically vulnerable. I'm terrified of catching coronavirus, but I'm even more worried for my boyfriend, who is immunosuppressed because of the drugs he takes for his inflammatory bowel disease. And I didn't want him to risk taking any chances going for small walks and drives. In some ways, I'm protected by my anxiety. It makes me be extra cautious. My boyfriend doesn't have that barrier. However, I am aware that I am also impeded by my anxiety on the flip side. So it's a very confusing situation. As I've started going for small walks in my local area, I do internal risk assessments. Things such as, is it busy outside? If so, is there a way that I can limit contact with others? Is there maybe a better time that I can go? I found that working out the quietest time to go for some fresh air is the best way to ease my anxiety. I know that going for walks early in the morning or on rainy days is better, and I stick to quieter back roads and footpaths rather than my usual busier route. And me and my boyfriend have a plan of action when we go for small drives as well. I've found that by planning every step from the house to the car and back again, by disinfecting door handles before I touch them, that by wearing my face mask to and from the car and washing our hands before and after, it's helped me regain some sense of control, and it's eased my anxieties. Coronavirus has been challenging for everyone, and everyone's experienced it differently. If you have a loved one who is struggling with the change, the best way to support them is to be kind and listen. Anxiety can be horrendous to live with. It's scary, it's exhausting, it can be life impeding, and the worst thing you can do for someone in that situation is to disregard their feelings. Saying things like, it'll be fine, don't be silly. It's dismissive and it makes us feel worse. You might not understand why they're so scared, but just be kind. You know, ask them if there's anything that ask them if there's anything you can do to ease their worries. Offer to help make a safety plan with them. Only they know how they're feeling, and they don't expect you to solve their problems. Just listen, be kind, and let them know that you're there for a chat if ever they need it. These next few months are going to be anxiety inducing for the clinically vulnerable. I know I need to adapt to living with having coronavirus just around the corner. I know that I can't protect my boyfriend in our house forever, and he will be sensible when he returns to work, but that doesn't make it any less challenging for my anxiety. I hope people remember that for some who are clinically vulnerable and for some who have mental health issues, they won't be able to do or they won't be ready to do the same things as everyone else in the coming months. Just be patient, please. We are trying.
Thank you, Victoria.
We've not lost Nick. Yeah.
I think we might have.
Right. Okay. I was going to say any comments in relation to that, but I already got my own hand up, so I'll kick off if I may. I must admit, over the last few months or many months, I've sort of sat and thought, has the penny really dropped with people? And there was a comment there about this lady's anxiety and seeing people on the beach literally as if nothing was wrong, and I too looked at that and I thought, what on earth is going on here? Interesting but vital that this lady said she took control really of her own internal risk assessment, and I too did that, because one thing you may not be aware, but I do the shopping because my wife hates shopping. I suddenly realised if there was one very, very high risk area, it was supermarkets. So I modified my thoughts about this virus, and I then started to go early mornings to the supermarket. I think the thing that apart from fear, and it is fear from people who are vulnerable, it's the message that I got from this particular presentation was that you've got to get control of your own environment and manage it to your best ability. Madhvi.
Yeah, so I was just reflecting as she was speaking. I could see a lot of the things is what must have gone through my mind as well through the pandemic. And I think being healthcare professionals, when there was mention about doctors losing lives, etc., through the pandemic, it's sort of, how do you balance your fears against your fulfilling duties at the same time? And yes, there's an element of anger when you actually see people on sort of beaches and things like that. But one of the things which is very obvious is obviously the impact on mental health, of course, through the pandemic, and also it will be after the pandemic, the impact it's going to have on people. And like Jane said right in the beginning, coming out of the lockdown is not going to be easy. So it is a slow process, and the impact it's going to have on people's lives and mental health is a huge thing.
Jane.
Thanks, Chris. So again, thank you to Seren for allowing us to share the story today. But this is just one case, when we've got a population in the UK of 68 million people. So if you think about, Seren's case across the population, not just for those that are extremely vulnerable, but for children going back to school, teenagers going back to do their A-levels, university students, adults that have been furloughed going back to work. It's going to be a very scary time for a lot of people, and the mental health, obviously, support that we need to provide for them is so important going forward.
Am I back? Can you hear me?
Yeah, we can. Yeah.
Okay, so we're trying Wi-Fi now. Okay, so I heard Jane's contribution and Madhvi's. Any other immediate thoughts? So I suppose once the commissioning body and commissioning organisation, it's what we do about the mental health issues that are going to arise over the next 2 years, and it might make us look differently at how we influence some of our mental health services going forward. I think it also puts into question a little bit the parity of esteem, which at one point was a good thing, but we might need to have a bigger proportion of spending supporting people's mental health, not just as a CCG, but in terms of focus across Barnsley as a partnership. I did see somebody's hand up. Was it Jamie?
It was. I was going to mention the same point as you've just done around just making sure that we've got our services together and supporting people as we come sort of through the next few months in terms of mental health. So you picked up the point.
Okay, sorry. You, Sue, Jay, very smart.
Thank you.
Sure. Okay, so are there any further thoughts, questions? If not, we'll Victoria for that story, very thought-provoking, giving us food for thought, and we'll move on to the next item in the agenda. So we've got, thank you, Victoria, we've got item 5, declarations of interest. Are there any new to share? No? Okay, so none to update. And we then move on to item 6, Kirsty, the patient and public involvement and activity report, please.
Okay, thank you very much. So this links into probably the story that we've just heard, the patient story. So there's 3 reports that I've included this month, and I think most of them we took to the patient engagement committee, the CCG committee last month. So we've had a good read through these reports, and I don't know if colleagues have read them all, but the engagement work we're starting to do, certainly over the past couple of months, has changed slightly. So we're not talking about decisions in relation to any commissioning changes as such. What we're talking to people about is their current experiences of healthcare services, just in general, in relation to living through the pandemic, really, and just trying to understand actually what does that really mean for us? What does it mean, you know, if you're trying to access particular services? What does it mean for your mental health and well-being? And that will help obviously inform our commissioning plans for the next 12 months. A couple of reports in there specifically. So we've started to pick up now on the COVID-19 vaccine. So a couple of reports, national one there from Health Watch England, that went out to talk to people about their intentions when it comes to having the COVID vaccine. And it feels a bit odd saying, you know, their intentions now, because it feels like the vaccine programme is moving so quickly, you know, and already in Barnsley, we've seen really fantastic figures and great uptake, but we know that there will be some people who are hesitant. There'll be barriers for people to take the vaccine, you know, and it's really important for us to make sure that we offer them the right kind of support, the right kind of information, and we can only do that if we know what they're thinking. So that's what we've been doing. So there's a national report from Health Watch England that starts to talk about some of those early findings, and then there's also a report from an organisation called Magpie, who we're working with the council. They've gone out to talk to people about all sorts of things during the pandemic, and in there it talks about the vaccine. So we had a good chat through it at the Engagement and Equality Committee. Health inequalities is clearly something that's going to be really important to us, and we'll be looking at it from that point of view as well. So how do we make sure all our communities across Barnsley have got you know, the right information and have got the right access for them. So those 3 reports mainly that I wanted to flag with you today. That work will continue. We'll bring back updates as and when we've got some more results, but that work is sort of feeding into the day-to-day business of our plans. So I'll leave it there for any questions. Okay, I don't think there's any questions. Everybody, I'm just looking at a sea of faces coming back to me. So you're on mute, Chris.
So I am. Have we lost Nick again? Looks if his Wi-Fi is not wifing. So what I wanted to say was really add to what you've already said, Kirsty, in that I would really commend members of the governing body, if you've not done so, to read the Health Watch report that they produced, Health Watch Barnsley, that is, that they produced. And I was so impressed with it that I asked for it to be sent to the South Yorkshire and Basset Law Lane members, which has happened. There's also a mention of something called Magpie, and this is an organisation, as Kirsty has said, who's working with BMBC. The thing that really staggered me was that they'd actually managed to engage, talk to, do whatever you'd need to do with over 800 people. And between Health Watch Barnsley and this organisation called Magpie, there's a tremendous amount of data there. And just picking up on what Jane Sivakumar said at the time was, well, what are we going to do with this? We're not going to waste it, are we? We're not going to put it on a shelf and forget about it. And I sincerely hope that we're not going to do that, and I don't think we will. But it was quite right and proper that Jane actually flagged that up and sort of stopped us in our tracks and thought, well, yeah, there is a lot of data here. And certainly through Barnsley Patient Council and through a meeting that I had this week with Barnsley Hospital governors, they are trying very hard now to engage with the people of Barnsley through their database, and it's not the easiest thing to do. So when you actually combine the numbers of Health Watch Barnsley and Magpie, there's 1,000 people there with quite interesting data. So that was all I was going to say. You know, I commend the report to the governing body so they can actually have a quick read of that. Everybody's gone quiet. Are you with us, Nick, or without us? Yes, without us. Okay, let's move on then. Any further questions of Kirsty? No? Okay, then let's move on to item 7 then. Do we have any questions from the public at this moment in time?
We don't. Okay.
Right, on to item 8 then, which are the minutes of the meeting we held on the 14th of January 2021. First and foremost, what I would be looking for is accuracy. It's a good record of our meeting. Secondly, happy to accept any minor amendments anybody wants to highlight to us. And then if someone or several of you could stick your hand up so that we can adopt the minutes. So first and foremost, are we agreed that this is an accurate record and this is a true record of that particular meeting? Yes, thank you. Any minor amendments?
Because it didn't work with that, it's on Wi-Fi. So
have you found any minor amendments you needed, Roxana? No? No. So at least 3 people stick your hand up and say, yes, we can adopt these minutes. Yes, thank you. Right, Nick, are you back? Oh, I've got him with his hand up, but you're muted, Nick.
Am I still muted?
Yeah, no, you're right now. I can hear you. We can all hear you.
Right. So I don't know what's happening. Jamie's coming to help. Essentially on page 2.
We're on to item 9, matters arising. Item 9, matters arising.
Right, so I had a point on the minutes and the system threw me out, so I wasn't able to contribute it. So right. This is on the minutes, please. Page 2. And it's the 210103, where there's a sentence, every individual staff member from his practice had volunteered to assist with the COVID vaccination programme. I think I did say that this wasn't atypical among practices, so I was proud of my practice, but I think it was not atypical among practices. So sorry about that, I'll do my best to stay connected.
Well, you know the best people.
Well, Jamie's a big help, he's next door. Okay, do you want matters arising, Chris? Okay. So, anything on matters arising? No. Am I still audible?
Yeah.
You
Right,
are.
so 210113, Jeremy, that's in item 11, isn't it?
It is, yeah. So that was delayed due to operational pressures. The colleagues will understand the rationale for that, but we're just picking that piece of work up now and expect to complete it over the next 4 weeks. So we'll certainly bring it back to the next governing body, but we'll bring it back to membership to the governing body at an appropriate development session in between as well, rather than wait 2 months to bring it back formally.
Okay, so in 210115, there's the attempted suicide follow-up service and work ongoing around that. I know information has been sent to the practices, but I just wondered if there's an update, Mark, around that at all.
There is, I know Michelle Thompson, there is a single page with mental health set out, but the suicide, I checked last night, isn't on it yet. But she was working on it when I last contacted her Tuesday.
Right, and the link with the mental health services is that through the single point of access. Is that progressing?
I must say I've not spoken to Patrick about that. I don't know how far that's got.
Yeah. And then quality highlights report. We've got item 14 on the agenda. And then other things are picked up in the risk register.
Yep.
And 210120 additional kit. I just wondered how much had been ordered.
So I don't know the detailed numbers, Nick. I just know that that Julie had worked with IT to replenish the break and fix stock. So there were additional ordered that should be available to practices as that come in. And we were looking at doing a similar thing within the CCG as well. But there has been some order, but I don't know numbers. Sorry.
Okay.
Yeah.
So is there anything else that we need to pick up on matters arising? And if not, can we then move on to Chris, Chief Officer's report, please?
Yeah, thanks, Chair. Morning, everybody. I've got a bit of an echo. Has everyone else got an echo? Has everyone else just gone to mute?
Yeah.
I think Nicky just gone to mute, Nick.
It's not letting me mute.
Okay.
Chris, you give your report.
I'll keep going then if you can. Right, that's better. Okay, thank you. So just 2 items for information today. The first one is the white paper the government published in December about integrating care and the next steps for the NHS. This is an ambition to move to a new system from 1st of April 2022. In terms of next steps for this, I mean, obviously the governing body will pay close attention to this policy as it develops. I think the second reading is scheduled in Parliament for May the 18th. So hopefully once we've had that debate, we'll have a refined a document for us to work with. But obviously it'll be a standing item as we come through during the next year. I think it's likely that the year 21-22 will be a transition year into the future. And then the expectation is we then implement from the 1st of April 2022. So I haven't got anything particularly else to raise on that, apart just to make sure it's in the public domain and everyone's aware of the future plans for the NHS. The other document we have on the Chief Officer's report today is a paper that was communicated to primary care about how primary care will vaccinate, how primary care will contribute significantly to the vaccination programme. I think it became obvious early on in the vaccination programme that primary care has a long history of managing vaccination programmes and a best place to deliver the majority of the vaccines. So the letter was sent to practice, and it was talking about a capacity expansion fund to support GP practices to contribute to the 7 priority goals set out in the letter, and specifically the monitoring support of oximetry patients and the identification of long COVID patients for support, to contribute to the current delivery model for COVID vaccination by supported primary care networks and our 3 local service sites, supporting the delivery of the COVID vaccination at practice level for care home residents and staff and housebound patients, and supporting the COVID vaccination at practice level through local clinics as this becomes possible through guidance and vaccine availability and supply. And we've certainly seen that as AstraZeneca has become more available. So this it was a national ask. We've obviously completed the action in a very pragmatic way in Barnsley, and it's enabled general practice to free up resource to support the vaccination programme and long COVID patients. So again, that's for noting today, Chair. So the business we need to do as a governing body is to note the 2 communications. Have we lost Nick again, do we think?
It's just trying to get it sorted.
Okay.
Chris Millington were talking, but he's on mute.
Okay.
Okay, thank you. Okay, let's move on then while Nick gets himself sorted out. So Jamie, on to agenda item 11, the COVID-19 response and phase 3 recovery update, please.
Yeah, no problem, thank you. So a relatively short report focused on just mainly a couple of bits. So since we last met, the roadmap for recovery has come out, and then an update on the vaccination. But just looking back, and I didn't realise when I were writing this, but just looking at the papers as I'm sat this morning, on page 1, the first line says, following declaration by the World Health Organization on the 11th of March that the COVID-19 outbreak be classified as a pandemic. So it's the 11th of March today, so exactly a year from that point. And reflecting back on the patient story, reflecting back on the work that we've done through Governing Body and the CCG and with our partners, the way that health services have changed and everything else in 12 months is pretty amazing, isn't it? And it feels like it's been longer than 12 months in one sense, but flown by in another. So a real milestone, really, being a year on from being declared as a pandemic. So just in terms of the paper, I mean, the first section just does set out the journey that we've been on, coming through last summer, relaxing some of the lockdown, allowing people to travel again and others, and then obviously an increase in numbers, which led to then reinforcing the lockdown as we came out into 2021. 22nd of February, so I've noted in the paper that there was an announcement around the roadmap out of lockdown, and we're now on the first part of that journey, aren't we? So a four-step process, which interestingly is made up of 5 steps, but the first one's 2 small parts. So just as a reminder of them for people that might not know, so the first started on the 8th of March, so this Monday, and I think the biggest part of that was around children going back to school. So all schools back open, wraparound care for children. And the other thing, I guess, in there was the ability to meet one other person outside socially. So not just for exercise now, but socially. So on a bench for a cup of tea. And we've not really had the weather, but it's sunny at the moment. So that was the first point. The 29th of March, it just goes a little bit further, still part of step 1, where they extend that to people meeting outdoors in groups of 6 or 2 households, the reintroduction of some outdoor sports, so opening of tennis courts, other things, some outdoor organised team sports, and I think significantly, and we'll see how this plays through in terms of people's behaviours, which again came out in the patient story. there's a formal end to the stay-at-home order on the 29th of March. So that stay-at-home order will end at that point. Obviously, still the advice will be to minimise travel, to minimise mixing and all the rest of it. So that's step one. Step two, on the 12th of April, we'll see some other things starting to open back up. So non-essential retail, personal care premises, outdoor attractions, indoor leisure, gyms, etc., and self-contained holiday for individual households. So that's the next step. 17th of May is the one after that. And at that point, for outdoors, most of the rules will be lifted. So groups will be able to mix in larger numbers. Indoor hospitality will also open back up, and indoor sports as well, which will include some large events with crowds and things. So each of these is opening us up a step more, and then subject to everything going as we would hope, and the infection rates not growing up and there not being any impact of sort of variants of concern, on the 21st of June, which is the fourth step of the vaccine, all legal limits on social contact would be lifted, and in effect at that point everything that has been closed or under restrictions would be open. Now, I would expect at that point that there will still be an whole range of guidance and things around how we continue to behave and work, but it will be on that basis. So that's where that is at. And I've set out in the paper as well the 4 tests. So 5 weeks between each step, and there's 4 tests that will be checked each time before we move from one step to the other. And they are, the first is around the success of the vaccine deployment programme. So I'll come back onto that one in a second. Evidence that the vaccine deployment is then having a sufficient impact in terms of reducing hospitalisations and deaths. So we're seeing positive position on that as it currently stands. Infection rates do not risk a surge in hospitalisation, and then an assessment of the risk is not fundamentally changed by new variants. So the new variants, the ones that might cause us risk. So they're the 4 steps. So that's the first section. There's a little bit in there around command and control, which we continue to review and monitor. So both internally within the CCG and across the partnership, we've still got arrangements in place, but as it currently stands, meeting less frequently as there's a trajectory in the right direction and we're not getting the same escalations. And then 5.3 just sets out where we are with the vaccination programme. And as ever, this is a fast-moving programme, so there's a number of things that are written down in this report that we've now moved beyond. So I'll just try to pick them up as we talk through. But just by reminder, the programme is made up of a number of elements. So vaccinations taking place through hospital hubs for health and care workforce, large-scale vaccination centres. Pharmacies are also on board now. They're bookable through the national booking system. Primary care services, which are delivered locally, supported by our general practices and Barnsley Healthcare Federation. And then likewise, sort of roving teams where we're going out targeting housebound and others. So current position is we've worked through and offered the vaccine to all of the people in the top 4 cohorts. So that would be those who are the more elderly population, those who are clinically extremely vulnerable, in care homes, health and care population. And the programme's now moved on to the next cohorts. So for primary care, the current focus is on people who have clinical conditions as identified by the guidance, who are therefore vulnerable and at risk of serious illness if they catch COVID, along with their carers. So that's the group, and primary care have been asked to focus on those cohorts as it currently stands, because that's where the relationship is. Through the national booking system, everybody who is, and in the report I wrote 65 to 69 and obviously above, is eligible to book through the national booking system. So we're receiving letters to say you can now book on this either online or through 119. That has quickly moved down. So as the vaccine has increased and the supply and getting people through, so at the moment or as of yesterday, those letters have gone now to everybody who is over 55. So anybody who is over 55, anybody who is in any of the previous cohorts, so clinically extremely vulnerable, health and care workers, and with clinical conditions, can all book an appointment at the national booking system, and they'll be offered appointments at Sheffield Arena, Spectrum in Wakefield, or some local pharmacy sites. People who don't want to access that or are unable to travel and want to wait for local services can wait for their GPs, and GP practices will make contact and book those patients in. Vaccine supply as it currently stands is of a good level and is coming through, and we would hope that all of the people in cohort 6, which is those with clinical conditions, are able to be vaccinated over the next couple of weeks, and then we can continue to make progress through the other cohorts. But I think, you know, great progress. All practices participating in the programme, working to identify the patients, and also then we've got our community services providers who are helping us to target some of the other cohorts of patients who are unable to get into practices. So that's where we are currently at with the overall programme. And then just to add to that, we're doing some specific targeted work, which I think is timely and really helpful to get out and vaccinate some of the groups of people who may find it more difficult to get to a centre, to help people with learning disabilities to come to the centres. We're doing some specific work with the homeless population and rough sleepers. Same for people who are in contact with substance misuse services to make sure that we're engaging gypsy and travellers, and also some engagement work with our BAME populations to make sure that we're out there getting the right information to people and encouraging uptake. And from last week, we started with the second doses, so second dose vaccinations for people who received their first vaccination 11 weeks ago. So that's commenced as well. So as it stands now, running forward, we'll be doing vaccinations for new people coming in, but also second dose vaccinations. So there's still lots of work, lots of effort going on, but as it stands, running really well. And as we can see from the numbers sort of starting to reduce, numbers in hospital reduce, having a positive impact. So that's all I wanted to update on. Thank you. I'll take any questions if there are any.
Nick, are you back? I've lost some of the screens actually.
Everybody's face has gone. Somebody's got an hand up. It says
Mike's.
Madwee's got a hand up.
Yes.
No, it's Mike.
Oh, is it Mike? Sorry.
no, it's MS Guest, it says, but I've got
It's
Mike
Mark
as well.
It's Mark.
Mark.
Oh, Mark.
I just wanted to point out, I don't know whether everyone was aware, but with the supply of vaccines, when practices are sent out batches of vaccine, they're being asked to use them as quickly as possible, ideally within a week, because if they don't, it can impact on the delivery of the supplies for the whole of Barnsley, because it's taken as that they're being hoarded and not used, and that's applied across the board.
Mm-hmm.
Yeah, that's a good point, Mark, isn't it? So we've adjusted the way that the supply is pushed out, and trying to manage that. So we book clinics and then allocate the vaccines out and work through. I guess, you know, nationally they're trying to manage the process. So each week there's a stock take of what vaccine is left, and when they're looking at what's left of the cohort, if places have got large stock that they haven't used the previous week, that's been taken into account, and then reducing the stock that is available, because we've all had to identify a sort of potential capacity that can be delivered. So if the flow keeps coming at the higher levels and we've got in stock, the view is that would just continue to build up, and it's stopping the vaccine going elsewhere. So we've got processes in place now, but that is an important point, that we as the vaccine comes in, each week the total vaccine stock is being used to make sure that we get through patients as quickly as possible.
Right.
We've got Madhvi wants to come in now. Come on,
Yeah.
Madhvi.
So yeah, just to add on to what Jamie said, I think BHF have been working closely as well, haven't they? Because we've had last week there was an extra vaccine of about 600, but I think they are ringing round practices to make sure. So that's been finished, and I think over the next couple of weeks we'll have another 500 extra, but that's also been sorted now. So I think yeah, James has been bringing down practices to see where there is extra capacity and whether they can use. But I think it's been a good story so far, because I don't think at any one week there was anything left and unused for that week.
Yeah, it's a great achievement, and I think we just have to recognise that and continue to recognise the input that everybody has. So, you know, all practices and a combination of staff from practices, booking people in, you know, supporting patients and doing the vaccinations, the sites that we've got running, and the volunteers, and then our partners as well. So it's a sort of, Kirsty started to use the Team Barnsley slogan, but it really does feel like a team effort.
Okay, Jamie, thank you for that. A very comprehensive rundown of where we are, what we've done, and where we're going to. So thank you. Great reassurance for the people of Barnsley and whoever ties into this recording of this public meeting. For whatever reason, I don't know what's happened, but I can hear people. I can't see anybody.
It's the same for me, Chris, as well. I think it's the same for everybody.
Yeah.
Do you think it's the system, or anyway?
I've never experienced it before, Chris. It's unusual, but we can hear everybody.
Okay, yeah. I can see Richard. I'm still assuming that Nick's out of the loop at this moment in time. So, if I may, and I've got a slight problem here in that agenda item 12, which is assurance report transforming care. We've got Patrick Otway against that, but I can't see Patrick anywhere on the.
Patrick's on now, Chris.
Is he? Okay.
Yeah.
So, agenda item 12 then, Patrick, you've got 10 minutes here for information and assurance, transforming care. Now, over to you, sir.
Thank you, Chris. So the paper starts by highlighting the context and the rationale behind the Transforming Care programme, which essentially, as we all know, is to ensure that wherever possible we can continue to support people with learning disability and or autism within the local community, rather than having them admitted as inpatients, and that when they are admitted, that we work to bring them back into the local community as soon as possible. So there are a number of processes that NHS England have implemented to enable this to happen, and one of the key processes is the care and treatment review for adults and the care and education and treatment review for children and young people. Now these have been undertaken nationally, and there's quite a variance in the quality of them since they were first implemented. So NHS England is trying to standardise that process to ensure that they are robust and that they include a strong multi-agency, multi-professional review, etc. They've also, NHS England have also implemented standard visits, which ensures that the case manager visits the adult patients at least once every 6 weeks as a minimum, and also that they visit the children and young people once every 4 weeks as a minimum. And this is to be able to look at how we can sort of discharge earlier to ensure that we have that support in the community. To provide support sort of early intervention and prevention and be able to target that, and NHS England are also expecting that clinical commissioning groups develop a dynamic risk register. So i.e. those children and people or those adults who are deemed potentially at risk of being admitted are put on a register, and we can target the prevention and sort of support into that to prevent those admissions. Now, in Barnsley, we actually funded the development of dynamic register about 2 years ago with SWIFT, and it was based on the adult model. However, for children and young people, it just isn't effective. So we are, from next week, there's a working group that's been established to look at developing a much more robust and efficient and effective dynamic risk register. Will therefore help us to target that early intervention and prevention, particularly into young people. The report also looks at the impact of COVID There is, with the COVID impact, there's quite a delay in some of the processes, some of the CTRs, etc., that have been enabled, and also sort of having people sort of on the virtual ward meetings and ward rounds and all the CPAs as well. So there's been lots of delays in that process, as we'd expect. But also, as people would imagine, there's also been an increase in the stress for the patients, particularly because of their routines, etc., have been impacted, and they can't do the normal things that they normally do. So there's lots of increased anxiety, and which has also increased the challenging behaviours. And we can see this impacting on the number of CTRs and CETRs that have been undertaken. So just in the last 6 months, there have been 9 CETRs, so that's for young people, and there's been 16 CTRs for adults. Now we can also see that they've actually been quite effective in Barnsley because they haven't resulted particularly in any admissions to hospital. We currently have 8 adult inpatients, 5 of whom are in secure care, so they're long-term patients, so they're not part of the 16 CTRs that have been undertaken. And we do have just 1 child currently admitted into hospital, but they should be being discharged fairly soon over the next week or 2. There is, for those people, for the patients who are long-term, there are discharge plans in place. Now, that's not meant to say that they are going to be discharged imminently. Those discharge plans can take over 18 months, etc., because they are sometimes quite complex and challenging behaviours, people, and often because there are forensic elements attached to them, there are restrictions in terms of the Ministry of Justice, and so that does input restrictions into where they can be placed and the type of placements in which they can be put into. There is one particularly challenging case at the moment that's going through where there's a difference in opinion in terms of the patient's lack of capacity, and that does determine where they can be placed. If they have capacity or if they haven't got capacity, it does determine what support they can have. So that process, where there is a challenge in that way, will go through the courts, and when the courts decide where that capacity lies, then a placement will be able to be classed as appropriate or otherwise. And it's all sorts of challenges, I think, that are continuing throughout, particularly when there is the Ministry of Justice limitations, and that does limit because there, within the market and the support provided, there are very few placements that some of the patients could be going to, and if they're not appropriate, there is a lack of provision in many areas. And this is often why, even though we're trying to keep people within the local community, it's often why sometimes there are out of area placements, and sometimes they're quite significantly distanced from Barnsley. But we are looking at how we can perhaps improve that market in terms of provision. And one of those things is, as we look at the end of the report, is the developments. And so that there's the Mayman Lane, which is a specialist housing development scheme, which is actually open this week, and it's open in Barnes, in Batley. And one of our patients is being discharged into that facility, which is an excellent facility. And it's those sorts of developments that we need to start looking at and trying to do, because these are particularly expensive and costly placements, not just in terms of finances, but also in terms of the sort of quality of life that these people have. So I think it's important that we start looking at how we can develop that market even further. We're also looking at how we can provide some sort of safe space for these people, in the sense of a safe space that could be like a step up and step down facility, which enables them to stay within the community rather than being admitted into hospital, which has its complications as well. The paper also outlines the assessment and treatment unit provision or re-provision. So for West Yorkshire and Barnsley, there were, as people are aware, there were the 3 ATUs, one in Wakefield, one in Bradford and one in Leeds. So the outcome of all the sort of engagement and consultation is that the beds in Leeds have now been closed, and the beds in Wakefield and Bradford obviously remain open. That will change, however, how the patients are admitted into that assessment unit, which is usually for sort of 1 to 6 week assessment period to decide what care package is needed to keep these people in the community. So we did have 1 block bed in the Horizon ward, which is the Wakefield facility, but the provision will be that it really is on a first come first served basis. So it may be at the moment that if there's no bed available, we will look outside of the area, but that's no different to what we do now. So if our block bed is actually has someone in there, clearly we have to go elsewhere. So we do spot purchase elsewhere as well, but we're looking at what that may look at financially for us going forward. So those discussions are still underway. So although the bed provision is closed, how that is going to be funded, and obviously because of the COVID impact as well. So those discussions are still going on, and we're being obviously keeping advised of what's happening within that. And I think that's probably all I need to say about that. So if there's any questions, I'm happy to take them. Thank you.
Patrick, your grasp of the detail is quite amazing. Every time you come along to talk to us, I'm always amazed by the amount of information that's contained in that head of yours. And I noticed it just came straight out. There were no notes, there were no hesitations, which is fantastic, really. So thank you for that. But without sort of putting it on the spot too much, in terms of policy changes, if you had to pick two that you are more than pleased and delighted to see, what would those two what would those two changes be, say, bearing in mind that the general public may be watching this, and to try and absorb the detail that you've just given us, it's quite trying for them. So just, if you could, just highlight maybe two things that where the people of Barnsley would benefit from.
So I think if we're looking at the policy element, I think the care and treatment reviews process is quite a key element, because this is the process by which the professionals, so social workers, psychologists, case managers, etc., education, public health, etc., all get round the table to discuss the young person or the adult, to look at what is the best form of support that can be provided to these people. And I think that is integral, really, to trying to supporting these people as best as we can within the community. So I think without that sort of multidisciplinary and multi-professional sort of meeting and review, I think a number of these people would be admitted into hospital, because without that sort of knowledge of the local system and also the what's available, it will be difficult, other than knowing that yes, they'll need to go to hospital because we need to care for them there to keep them safe. But there are lots of ways in which people can be kept safe with just a little bit of support from different professionals within either their own home or within a community setting. So I think for me that is a key one. I think that's probably why NHS England have sort of tried to standardise, because in some areas, some of the CTRs, for example, the care and treatment reviews, they've only been taken, like you said, like a chat for 1 to 2 hours, whereas actually what they're suggesting is that the process should take 1 to 2 days to really ensure that you understand the needs of that person, and therefore you can put the most appropriate support and provision in place in the community. And obviously they continue to be reviewed, so that's why they're wanting to look at, even if people are admitted, they want to get them out as soon as possible, because as we know, people are better and have better quality of life and better outcomes if they can be supported within their own home rather than being admitted into hospital. So I think that's the key element there. And for me, the other aspect will be having a really robust and effective dynamic risk register. So where there are people who are on the periphery of perhaps being admitted, that we are made aware of them, and then all the services can be targeted as to say, so what is it we need to do to prevent these from going into hospital or into some inpatient care in some way. So I think that those two, I think, would give the biggest benefit for the people in Barnsley. And obviously we are looking in the Transforming Care programme. It's only those patients with learning disability and or autism that is the focus of this sort of cohort and this programme.
Patrick, thank you for that. It certainly highlights your passion for the work that you do, so thank you. Any more questions? Anyone like to ask Patrick for any more assurance? I can't see everybody at the moment, so if someone can see that needs to come in, then please come in. No? Okay. Thank you, Patrick. As always, I've already said it, fantastic presentation. Thank you. So, just one, Patrick, are you still with us?
I am.
In terms of jargon, you said a couple of times CTR. Just explain for the people of Barnsley what CTR is.
It's care and treatment review.
Thank you.
CETR is care and education treatment review, which is for young people.
Many thanks. So on to agenda item 13, which is the assurance report, care homes and enhanced care by our chief nurse, Jane Sivakumar. Jane.
Okay, thanks, Chris. So the purpose of the paper today is to provide assurance to the governing body on the delivery of the Barnsley Enhanced Health and Care Homes Delivery Plan, which is priority number 11 in the governing body assurance framework. During the first wave of the pandemic, Barnsley positioned itself to be able to respond to the challenges of the pandemic and a number of bronze groups were set up, with one of them being the out of hospital care delivery group, which met on a daily basis. The care homes delivery plan was initially set up in response to 2 documents sent to all NHS organisations and local authorities when it became clear that many care homes were reaching crisis point in terms of levels of infection, staffing shortages and deaths in the resident population. The 2 documents set the requirements of a local universal offer to care homes and were primarily focused on infection prevention and control, hospital admission prevention and discharge, and financial support, with direct wraparound support from local NHS and social care services. Specific reference was made within the documents to the enhanced health and care homes, and it was evident at that point that there were elements of the COVID-19 specific support that covered key elements of the enhanced health and care homes, and there was a real opportunity for us to drive the enhanced health and care homes at pace. The care homes delivery plan was commissioned by myself, the Director of Public Health, and the Executive Director of Adults and Community at BMBC, and was jointly programme managed between both organisations. It was felt at the time that the delivery of the plan sat best within the bronze group, which was chaired by myself, as the group had the operational leadership, attendance and service level structures to enable mobilisation of support at pace and scale. Appendix 1 in the paper includes the current version of the plan, and with the plan that sits within an overall workbook and includes underpinning national, regional guidance and a risk log. During the second wave of the pandemic, the care home support and key initiatives have continued. However, there has been less focus on the overall longer term plan because it was necessary to ensure that the core support continued to be delivered to the care homes during the second wave of the pandemic. As the vaccination programme progresses and operational pressures ease, there has been an opportunity for us to collectively review the plan. At the bottom of page 2 and the top of page 3 in the paper, there is a long list which hopefully articulates to the governing body the significant progress that has been made over the past 12 months. The list includes, and I've just pulled out 3 main points because obviously the list is much longer. The first is infection prevention and control training to all care homes. So in May last year, all CCG chief nurses were given 2 weeks notice to ensure that all their care homes were trained in infection prevention and control, PPE and swabbing, and due to the collective efforts of partners across the borough, across Barnsley, we achieved 100% of training to all the care homes within that 2-week period. The second achievement is the delivery of the primary care network DES, in particular the alignment of care homes to a primary and secondary GP practice and a named clinician for each home, coordination of ward rounds, multidisciplinary team meetings and consultations. So with regards to next steps, the first is something that I started to work on just before the pandemic started, and I picked up again a couple of weeks ago with our local authority partners, and that is to set up a support network for the registered nurses who work in care homes, and that's to provide peer support, training, professional and clinical supervision, with the ultimate aim of driving up quality. The second is to continue to work with our commissioning and provider partners to embed the enhanced health and care homes and the other care home actions contained in our action plan. The third is to support the digital capability work across all care homes in Barnsley. And last but certainly not least is to work with our safeguarding colleagues in BMBC to improve the communication between the CCG and BMBC to strengthen our safeguarding processes. So before I finish, I would like to add that the daily operational support to care homes throughout the pandemic, as well as implementing long-term changes to the way care and support is provided, is a true testimony to our team at the CCG, our care homes and our provider and commissioning partners who have really worked relentlessly together and as one team throughout, and I feel really privileged to have been part of it. So I do hope that this provides the governing body with the assurance on the delivery of the Barnsley Enhanced Health and Care Homes Delivery Plan, and I'm happy to take any questions.
Jane, thank you for that. I was going to put you on the spot and say, you know, what are you and your team really proud of? But I think you've answered all of those. So thank you for that. Just pulling one or two things out which you said was significant. One, you talked about infection control training within care homes. Then you talked about PCN DES, and then you talked about support for registered nurses within care homes. So again, all good, strong stuff. But for the people of Barnsley who, again, may be looking in the next few weeks, I wonder whether you could very, very briefly explain PCNs and DES.
I can, but I'm sure that one of my colleagues, maybe Jamie or Jeremy, would be in a much better position to explain that. I'm sorry to put Jamie on the spot, but I'm sure he will be.
I'll come in, or even some of our GPs. So PCN is the primary care network. So network of all of our practices coming together, and they're coming together to deliver the direct and enhanced service around PCN. So that's a specific part of the contract to deliver additional services, bring additional roles into general practice, and improve outcomes for patients in general practice. So in Barnsley, we've got one primary care network, and there are a number of sort of requirements of the primary care network. One of those is to deliver a specification around enhanced health in care homes, and there are 7 others which include structured medication reviews, personalisation, anticipatory care. There's one around cancer, so a number coming forward. So that's what the PCN is, and the DES is just an extension to the general practice contract.
Jamie, thank you for that. Jane, you said you were proud, and you've every right to be proud of the work that you and your team have achieved over these last 12 months, together with the whole of the CCG team. So thank you.
Thank you.
I thought maybe we'd rescued Dr. Balash, but
we have. We've just Angela's just trying to get it sorted.
Right.
He's on my sign-on at the moment.
Right. Okay. Well, again, a very comprehensive report of what's happening in Barnsley from our chief nurse. So just to keep the ball rolling while Dr. Balash comes back online, if we could go back to Jane for agenda item 14.
Okay, thanks, Chris. We have got Joe with us. Joe's now on the call. He was obviously leading on this area for us. So I'm going to hand over to Joe Harrison, if that's okay. And Joe's our specialist portfolio manager, who is responsible for all the complex cases, so section 117, out of area, locked rehab, children's and so on. So I'll hand over to Joe because she's really the expert in this.
Okay, thank you.
Thank you.
Good morning, Chair and members. This report, this paper was requested at the last governing body when I reported from the highlight report about the out of area locked rehabilitation situation. It really is to cite governing body further on the issues and risks regarding a particular cohort of high risk and high cost patients within the current system, and it outlines the mitigating actions that we're taking and that we're planning to take. So basically, the Barnsley CCG delegates the commissioning of the out-of-area locked rehabilitation beds for adults with mental health needs. It's when they've come to the end of an acute phase of treatment but require a period of more focused rehabilitation before they can be discharged. This is done via a devolved budget to South West Yorkshire Foundation Trust, SWIFT. I'll refer to them as now. And I've outlined in Appendix A the process that we've developed, because there was a number of issues around how those placements were procured, and we felt we needed a little bit more of a robust process in place. So that's in Appendix A, and that stands at the moment. All the cases are referred via the commissioning panel. I attend that, the SWIFT general manager, and then a bed management service manager, and it's signed off by the deputy director of operations, any care that's agreed. We know there's been significant pressures over the past 2 years with that budget. And the SWIFT Director of Operations wrote to the CCG early in 2020 to outline the budgetary pressures, citing the increase in complexity and risk. And the pressures really increased during 2020. It's evident from all discussions that we've had, from me attending panel and out of panel requests, that we've got a cohort of young women particularly who are very complex and challenged services. And the general theme of these young women is most of them have been looked after children. In fact, I think all but one of them that we've got in this really complex cohort are, and they are also diagnosed at some point. They've had several diagnoses, which I think that's something we need to look at in a different. Sorry, my battery's just about to go. I do apologise. Yeah, so the diagnosis of these stands at the moment for these young women is emotionally unstable personality disorder, or some kind of other personality disorder, either standalone or with that, but that seems to be a baseline diagnosis. And also some of them have got eating disorder. Very complex family issues, obviously, with the looked after children, but the ones that are not looked after have been children in need anyway. So we're seeing a pattern with these young women. So at the moment, we've got 5 of them in the system. They're particularly complex and particularly challenging. Histories of multiple acute admissions leading to the out of area locked rehab placements. And I've just asked for a breakdown of the placements and the spend from SWIFT, and it looks like we've got some of them who have been in the system for 3 years since they transitioned into adulthood, which is something we really need to look at. They tend generally to have high levels of staffing and observations, varying from 24-hour one-to-one to episodes of 3-to-1, some of them 24-hour 2-to-1 staffing. Even notwithstanding that, they are still able to self-harm and harm others, and some of the placements have broken down. The locked rehab placements are actually independent hospitals usually. So they come out of SWIFT Acute into an independent locked rehab hospital. Those hospitals then say, we can't cope with them, they're too challenging. Can we have a psychiatric intensive care bed, please? Again, that is often an independent bed, because it's sometimes a lack of a bed availability in SWIFT that leads us to have to do that, or that they're even too challenging for that system to be held in that system with other patients. Because what we're finding with these young women particularly is that they have met each other in the system, and they tend to encourage each other to self-harm, harm others, and sometimes there's suicide pacts developing, things like that. So you can see how complex these are. And when I just had some rudimentary information on the budget, we've got 5 cases that have added about in the region of £1 million of the budget pressure. I've since done a bit more analysis of that, and it looks like we've got 2 patients who have actually cost about £800,000 of budget pressure. And that budget is now in SWIFT, it's double. They've spent double the budget allowance for the year. So it's running at about 4 million forecast for the end of March. It's a significant cost to the NHS, obviously, significant cost to the taxpayer, and the patients are stuck in a medical model pathway. Doesn't appear to be promoting the recovery and rehabilitation. The outcomes are poor, and the thinking behind a lot of the conversations that I have about their future is really nihilistic. It's what's the point? They have no hope. They're going to be stuck in a system, and really sometimes the only recourse we have is to actually refer them into NHS England for secure services, but they're not suitable for those. So it's really not a good picture for these young women. They basically, what we're looking at now is achieving some better outcomes for them. Obviously we need to gain some financial efficiencies, but I think that needs to be secondary to gaining the right outcomes, or at least offering these women some hope in the system. So I come on to the mitigating actions now, and some work has already been undertaken. We're looking at a detailed review of the SWIFT out of area budget. I'm asking for some analysis of that, and I'm also asking for that measured against the bed days that they have in acute as well, and in their own PQ. So I'm trying to look at that in the round really. And this will be discussed at the commissioning priority meetings that we have and the clinical quality boards that we have. It's tabled for discussion at the next meetings. Most importantly, the next part, I think, is that we've commenced discussions to look at feasibility of community options for step down and admission prevention. I think that's really important. We're sending these young women out of area, and what we know about them is that until they're probably about 25 and possibly 30, they're not really treatable in those systems, and so they're out of area in a model that doesn't work. And our thinking behind this is in terms of long-term plan and best practice, and what's right, you know, in human terms, is that we should offer them some opportunities locally to be housed and have the right approach in the community. And what we're looking at is something like a step up, step down system with wraparound support if they come into crisis. Again, there's a strong link to looked after children and transitions planning, and we've started some discussions with BMBC partners and NHS England regionally and nationally. I'm talking to the Leeds Personality Development Pathway Manager and also the West Yorkshire Commissioner for Complex Care around what have been done in other areas and what ideas we possibly have that we could do at place and possibly model across to the system as well. We've now appointed a complex case manager also, who will support Swift Care coordinators to give some real clinical challenge and confirming the treatment interventions that these young women and men. We've had a recent development with 2 young men, I must add that, and to look at the cost of observation levels in inappropriate cases, because I think we really need to challenge that and actually say to these independent providers, so what are you doing and so what does that mean, and really dig down into that. It's planned that we'll request a journey of 2 of the patients. I've already started that process and looking at the timeline of their journey through all the systems and saying, so what model have we applied, how has it worked, what's not worked, and look at what we can, you know, if we could change that thinking a little bit in our own systems and in the systems that we're commissioning as well in the independent. So as I've just said, it's aimed at understanding a number of factors, but that's in early days as yet. But I think we owe it, you know, to our own assurance and to the journeys of these young women and women who will follow them, because we've got a number of young people coming through the transition system through CAMS, and I think we really need to get to grips with this and offer some alternatives. So I'm asking the governing body to note the issues raised and the mitigating actions to reduce the risks. Has anyone any questions?
Thank you, Jo. It's quite staggering to me as a lay member, and I'll stress lay member. I'm nowhere near close to the clinical side of this, but it's quite incredible that when you see that potentially 2 individuals who are clearly getting an awful lot of people's time, and in terms of monies available for the people.
Apologies.
The £800,000 you've mentioned, £1 million for 5, budget heading towards 4 million. I'm going to stop there and invite some comment from my clinical colleagues. But thank you for the report, very comprehensive, a lot of work put into that, and the things that the headlines that I picked up was, you know, we've got to give hope, we've got to look towards the future, we've got to, you know, CAMS again, that area of work, you know, and I did mention it yesterday at the hospital governors meeting, that in terms of mental health, you know, it's all right concentrating on one area, but the children start, and if we don't capture it, if we don't slow it down, it just goes on. And here we have an out and out position of escalation in terms of monies being spent. Dr. Balash.
I am on Anja's equipment now, so everything should be absolutely fine. Thank goodness. Very embarrassing and very, very frustrating when one's prepared and then here's a conversation that one can't enter. So on this point, thank you, Joe, but there is something around the governing body remaining cited on this and the mitigations. And obviously there are some seriously damaged people in this system. So part of it is preventing the flow in, which is the CAMS things that Chris has mentioned. I think the other bit is how we keep sighted on these mitigations and improvements. Would therefore put to governing body that I can think of two ways of doing that. One is that we go to a risk register, or two, that we receive an update, because the mitigations, I think, are not, from what you're saying, the community sort of approach for some of these people will take quite a bit of modelling, won't it?
It's not a quick fix, Dr. Balash.
It's not a quick fix, that's what I was thinking. And they're complex people, and they seem to have, some of them, almost formed a compact or mutual support group within.
Yes.
For negative outcomes.
Very risky.
Yeah. So I wonder if the governing body would like to, and how you would feel about this, Joe, give us some sort of update, perhaps in 3 months, or whether you feel, Chris and Richard, that we should pop this on the risk register. It might not be something that lends itself easily to the risk register. It might be something we have to follow with update reports at governing body. So open to views on that. Thanks, Joe.
Yeah, I think I would agree with that, and it might be difficult to condense all of what we've just heard into something that would fit easily onto the risk register, and maybe, as you suggest, Nick, scheduling an update in a few months' time might be a better way of getting assurance to the governing body.
Yeah,
I'm more than happy to do that. We are going to trial one of the young women in a community model if we can. We've got some meetings pending about it. It isn't without risk, but we are looking at a proper risk assessment around all sorts of safeguarding issues, like the old VARM type policy, the self-neglect policy. So I'll definitely update in terms of that case and the other work.
Okay. John, morning, John. I can see your hands raised.
Yeah, I'm just wondering, I may have missed something here. Is the cost escalating because we're actually putting these people into private providers? So the question is, if you're looking at an overspend of 4 million or thereabouts, has anyone actually thought about speaking to Swift and see if they're prepared to set up a very specialised unit where they have the same sort of staff they can employ in the community in that unit? I would imagine the cost would go down. Anyone thought of that?
I think, Dr. Harbour, the answer in my head is yes. It's becoming apparent that there's a shortage of PQ beds within Swift, and we thought that was pretty much specific to the pandemic, but I think we're seeing an upward trend in the numbers and acuity of people coming through the system. And certainly I think there's some value in going back to Swift and looking at some of the units, but not doing what we've always done in some of those units. There needs to be a different approach. DBT therapy works with some of these young women and men. I'm not convinced that's where the model that we're using in the independent sector either, as well as within Swift. So there needs to be a conversation about models of care and recovery, and how they manage them within those units.
Have we looked anywhere else to see what other people are doing?
We are doing.
Yeah, I think you have a lot of property in the NHS, and I think the cost would come down considerably. You just need the staff to staff the units, and unfortunately, whenever you go to the private sector, it attracts a premium price, doesn't it? Because they know they'd have you over a barrel.
I think so, Dr. Harbour, and I think one of the key messages from me though today is that the medical model doesn't always work with these patients. So we have to do that analysis of what's the right approach, who we've got in the system, what they need, and what works and what doesn't work. And that's why we're trying to map some of the journeys through.
Okay, Mark, you had your hand up.
Yeah, it seems almost like lock rehab's a bit of a misnomer in these cases, isn't it? Because if we're talking about them lacking hope for a future, we're not really rehabilitating, are we, in those units? It's more containing.
They shouldn't be in the system for 5 years, and some of them have been.
And it certainly doesn't seem to be an answer. And you mentioned there's risk associated with community approaches, but there's a risk in what we're doing now, isn't it? You know,
absolutely, they are being harmed. Yeah, they are being harmed and harming others. We've had multiple hospital admissions for 2 young women ingesting metal and all sorts of other objects, and so and that's with 3-to-1 staffing. So we really need to get to grips with that.
Okay, thank you. Jane, did you want to come in?
Yeah, thanks, Nick. It was just to acknowledge really the investment that the CCG's made into this area, and with the number of appointments that have been made into the CCG. So Jo obviously being one of them, Katrina being the complex case manager and a support officer. So, you know, there has been investment made into this area so that we can truly focus on improving outcomes and obviously reducing the financial spend that we've got in this area. So just wanted to acknowledge that you know we are doing a focused piece of work on a number of areas of this portfolio, as the governing body's aware.
Thank you, Jane. Nigel?
Yeah, just on the transitioning from CAMS into adults. This has been raised a number of times in the past. We had a presentation regarding what young people thought was a lack of transition support. So I don't know, I'm sure that's improved, but these are the extreme cases. But if that transition isn't working for these, is it working for others? So it's just, it is an area that I think ought to be looked into, and I'm sure you are looking into it, Joe, for these people, but perhaps on a wider basis as well.
It is, yes, and there is an issue around the looked after children cohort, and Barnsley are I hate to use that phrase, but a net importer of looked after children, and we're responsible for them even when they leave the district. So it's really important that I think we get to grips with that transition phase and with them as young people. So with managing the children's service at the moment, with the continuing care service, I'm hoping to at least have an oversight of what's happening and try to feed what I know and what I find and what I'm doing into those early years, and you know, into the all age strategy, really into the start well, live well and age well. You know, as a full, it won't dovetail perfectly because it never will when people transition from children to adults. But I think if we take the 0 to 25 element, get that right, and then put the structures in from, you know, sort of 14 plus within that, something should change for the better. But there's a lot of work to do by all partners.
Yeah, I agree, but I think the more seamless that transition is, clearly the better for everyone.
Okay.
My opinion.
Yeah.
Thank you. John? John?
I haven't got my hand up, have I?
Put it down then. Okay, thank you. So now then, there's somebody else coming in. Who's that?
Patrick.
Patrick.
Thanks, Nick. It's just to sort of remind people, I suppose, that the new co-produced service specification does say that we are looking towards delivering a CAMS services 0 to 25. So that is one of the areas that we are keen to develop and transform into. It's also the ask of the NHS long-term plan, and it's also one of the key asks of the children and young people themselves. So it is a priority for us to sort of deliver that certainly over the next sort of 2 years.
Okay, thank you, Patrick. So I think as governing body, thanks Joe, thanks Jane, there is therefore an ask of you to bring some update report in about 3 months, particularly with regard to the mitigations. I think it would also help if you look at the minutes of governing body when they're adopted, so that some of the points that have been brought up in this can be reflected in terms of how they've been progressed realising pace is slow on these things, but in the update report, particularly I think the flow of people into the system and the management of those within, but also that transition element which in some of our discussions at governing body and development sessions has come up repeatedly. So that will be good. So thank you for that, Joe. Thanks, Jane. Thank you, everybody. Thank you. So we can now move on to item 15, please, Jane. Quality highlights report.
Okay, thanks, Nick. So the Quality and Patient Safety Committee met on the 18th of February, and it was agreed that 5 quality issues should be highlighted to the governing body. Apologies, the paper says 6, but it's actually 5. So the first area is the digital plan for care homes and is RAG rated as green. So the committee received positive assurance regarding the good progress of the digital ability in care homes project, with the aim of the work to implement a basic standard of digital ability in care homes. The second is GP contact activity and is RAG rated as amber. So the committee received for the very first time a report showing the number of general practice contacts for 1920 and to date in 2020-21. And the committee were assured that the data provided positive assurance that the level of contacts was similar to the previous year and would provide the public with confidence that GP services were being maintained during the COVID pandemic. The committee did, though, agree that further work was needed to understand whether patient experience information of remote consultations would shed some light on the low level of video consultations in 2020-21 compared to 2019-20 and the high number of DNAs. The third is care homes quality assurance, which is RAG rated as red. So I raised a concern to the committee regarding the level of assurance the CCG currently receives around the quality of clinical care in care homes. The committee noted this concern and agreed the topic should be a standing item on the committee agendas going forward. The fourth is ophthalmology services and is RAG rated as red. So the committee was briefed on the discussions held between our medical director at the CCG with Barnsley Hospital, in particular the out of hours cover for the service and the outcome of an external peer review. The committee noted the update and agreed that further assurance should be sought at the Barnsley Hospital Clinical Quality Board. The final area is with regards to the D1s, or the discharge information that goes out from the hospital to primary care and is RAG rated as red. The committee discussed the long-standing risk on the CCG's risk register relating to the D1s and the outstanding re-audit work required by the CCG to provide assurance on this issue. The committee noted the Trust's feedback that it was not in a position to undertake the re-audit due to COVID-19 pressures. So the committee noted the update and agreed that they needed further assurance from the Trust, and the re-audit of D1 should be pursued at the Barnsley Hospital Clinical Quality Board. So thank you, Chair. That brings me to the end of this agenda item, and I'm happy to pick up any questions.
Right, okay. Any questions? I've got something. Mark?
I just wanted to point out on the last one on the D1s, the other issue was the discharge medicine service, which we felt added to the risk. It's currently restricted to NOMAD medication, patients with discharge with NOMAD medication, but we were concerned about the possibility that it would add to the risk if it was extended to all discharges, and that's a process whereby medication on discharge goes direct to pharmacy to make changes.
Thank you. Any other questions for Jane? Okay, so Jane, I've got a couple of points. I think the first one is GP activity, and I think what we're comparing here is a number from one year to another of video consultations. I think what we have to recognise in the past 12 months there's been the advent of lots of other types of consultation, and video consultations may not be the best way of doing things, they may not be the most popular way of doing things, and with people taking pictures on iPhones with telephone conversations, the use of Dr. Link and various other ways to communicate to practice. I don't think we should, if we by all means do this work, but I don't think we should take for granted that the video consultation is either the best or most popular way of communicating between patient and healthcare professional. The second, so that's one point, and I really would like you to know that. The second one is the concern about the clinical quality in care homes. And perhaps for outside this meeting, I'd like to understand where that has come from, because there's a big focus on care homes at the moment, and with the advent of the PCN care home direct enhanced service, with the use of clinical pharmacists and medication reviews, with anticipatory care plans, with the joining up of the community team, I think it's quite possible that care home patients are being looked after far better than we think. So if there's a care about the clinical, concern about the clinical care, I really would like to know as a GP, and I'm sure my colleagues would, and my healthcare professional colleagues, not just GPs, about where that concern comes from. And I'd also like to understand how it's evidenced, because at the moment I think the quality of care in care homes across not just Barnsley but beyond has really gone up in terms of the number of inputs that are available, and also within that is 24/7 medical cover in care homes, either from GP practices or out of hours, and other places. So there is quite a lot going in. So perhaps outside the meeting, I'd like to understand that a little bit more. Thank you. So I've got somebody here that's got their hand up. Just a minute. Patrick, is yours a legacy hand? Must be. John,
it's John and Jane, yeah.
Yeah, I just wanted to wish Madvi and the CCG all the best with the D1s. It's not a new problem, is it? Let's be honest. It's like knocking your head against a brick wall and getting nowhere. Yeah. Best of luck with that one.
Okay, Jane.
Thanks, Nick. With regards, just going back to your thoughts, Nick, about the quality of clinical care, I think my concern is more around how we receive the assurance from the local authority. How can we ensure that we are improving the quality of clinical care? So it's not that it's not happening, it's just how can we get the assurance via the processes that we have or have not got in place at the moment.
Right, and I think that's really important to clarify. It's the information we receive, and therefore, having received it, what we do with it, rather than there's a concern about the clinical care of patients in care homes, which is, I think, how this read to me. So yes, thank you for that clarification, Jane. Mike?
Thanks. Yeah, I think to carry on what John was saying about the D1s, it's used to be every meeting he used to talk about D1s. We haven't heard about from him for a while, but I think the D1s, the GPs know that D1s often aren't very accurate, and therefore check them out when the patient comes out of hospital. And the big worry is that if these are going straight to the pharmacist, who will just prescribe the drugs, that some major incident will result from them. And I think in the past I don't know what else we can do about D1s, because we seem to have tried everything. But I think in the past the GPs have minimized the risk, but in future there is going to be a major, I think going to be a major problem with it going straight to the pharmacist.
Okay, thank you. Jamie McGuinness.
Yeah, it's just a comment about care in care homes. I think whilst the staff in care homes will always offer the best care that they can, we know there are problems with the care that's being offered because of the simple things like the staff turnover. You know, a care home can expect to lose up to something like between a fifth and a third of its staff on an annual basis. And that alone is going to have a huge impact on the care that they're able to deliver. So hopefully with the new kind of care home support that the council and the CCG are planning to offer, that should reduce and the care should continue to improve.
Yeah, specifically this talks about clinical care though, Jamie. So I think actually your points support mine in that we're closer to the local authority supporting the care home staff.
Yeah.
All those things we are working better, but it was just that clinical bit that I wanted some. But I think it's the general care, and there are some elements that we well know of and that we are striving to improve. Thank you. Okay, so if there are no further questions or points to make for Jane, thank you, Jane. Can we move on to then item 16, Children's Services Commissioning Update? Patrick, please.
Thank you, Chair. So, as members are probably aware, I could probably talk for hours on the Children and Young People's Commission stuff, but what I've tried to do is probably highlight some of the key points which I think will be helpful and useful for members to be aware of. So obviously, I think members are fully aware and informed of the CAM service and the newly co-produced service specification. But for me, I think what the biggest change is that the system doesn't see CAMs as being the only and the best sort of service to provide support, but actually that CAMS is now beginning to be seen as one small part of a much wider system. And that's why we're looking at the iThrive framework. So now I've mentioned the iThrive framework, but we've probably not done an awful lot of detail, but I think the pictorial in there really sort of helps bring that into sort of focus, in that it is a system-wide approach, and it is about that sort of getting advice and then getting with support, etc., and getting the help and the more help. And so I think that is, for me, is the biggest change that we're going to see as we transform delivery of the CAM service into this new model, because it is very dependent upon having that much lower level support systems available as opposed to just the CAMs. So I just wanted to bring that out because I think that's a really important sort of and key focus to sort of have in mind. To enable that transformation from how CAMS has been sort of seen in previously, and then to get that into the much wider system, we have established a Children and Young People's Mental Health Services steering group, which does have the clinical representation from CCG and SWIFT, who provide our CAM service at the moment, but also has management representation and public health representation on that. And we're widening the membership of that to bring into the mental health support team, so Compass, assigned to be part of that as well. So it is being seen as a system-wide approach rather than just, for example, being CCG and CAM. So I think, again, that sort of reinforces that focus of it being a system-wide approach. I've outlined in the paper some of the sort of key elements that the steering group has started to work upon, and it is about clarifying that expectation with the providers to what it is that we actually expect, linking it into the target, etc., within the service specification. It's about that openness and that transparency as well that all partners can bring to the discussion. We're looking at reviewing and looking at the sort of clinical pathways, because there's some redesign in the pathways, so they're now looking at just 4 key areas, which are the ADHD, the children care pathway, eating disorders, and the main priority being that single point of contact, which brings in the whole system. So that we're trying to sort of develop that and to bring that at pace, really. We do also look at some of the sort of service pressures as well, which again will be within ADHD, and where perhaps there might be some other gaps within the current resourcing. And I'll talk about that much more in this afternoon. I think probably what is important as well is to feed back to governing body the success of the waiting list initiatives in relation to CAMS that the governing body members have funded over the last 18 months particularly. And it's just shows that if you look at the table, I know there's lots of numbers in there, but I think the key bit is probably in the table, which shows that at the end of January, there are just 66 young people waiting for treatment, as opposed to at September 19, 330. But given all that the referrals have continued into CAMS even through lockdown, that overall there's been a reduction of 533 young people on the waiting list. And I think that really is a positive picture to present, but we need to maintain that success going forward as well. For me, what that brings about really is that the strong relationship that's been developed between CAMS, between ChiliPep, between the mental health support teams in schools, because without that collaborative partnership working, those figures would not be as good as they are, and we wouldn't be getting that support for the young people that we desperately need as well now, particularly in terms of the lockdown and the additional work that's been undertaken by everybody to ensure that children and young people are supported when they return to school, but also whilst they've been working, doing their schooling online at home as well. So that's been really key, and there's been bespoke policies, etc., bespoke resources made available from educational psychologist areas, from public health, as well as the wider sort of Yorkshire Humber clinical networks as well. So there's been a lot of focus on developing that support for children and people whilst they've been in lockdown. And because we are aware, obviously, there's an expected potential increase in the demand for mental health support, particularly as children start to return to school. And so that will continue to be looked at. Going back to sort of the transformation as well, what's been key important has been the transformation lead post. So this is a joint post between the CCG and Public Health, and the transformation lead has done a significant amount of scoping work and has looked at all of the resources that are available within Barnsley, so not just those commissioned by the CCG, but commissioned and provided by other partners. It's a significant piece of work, and obviously we've not shared it here because it is quite wide. But what I would like to do is perhaps share that for comment, because what we're looking at is the recommendations of that report to move forward. So I think it would be important for governing body members to actually provide some sort of reflection on whether they are the priorities that they would expect, whether the recommendations, the actions are what they would expect, and try to influence that. So I will ask that report is actually, and that scoping exercise is shared with governing body members, and if they could then provide some comments and reflection on that to me directly, that would be really helpful. And in terms of acute and community paediatric services, members will be aware as well that we did undertake an independent review of the acute paediatric services probably towards the end of 2019. There were a number of recommendations from that report, and that work has been halted because of the impact of COVID. However, it has recently been picked up, and there's currently two pieces of work, two service specifications that are being looked at, one in terms of the Children's Assessment Unit and the other in terms of the Children's Community Nursing Service. And the intention will be that once there's initial draft of that document, they will be brought to the CCG's clinical forum for further discussion, so that the CCG clinical team can therefore provide that influence and direction, so that the services that are provided are the services that are agreed that are needed, etc. The key difference going from this April, actually from next month, will be that currently the Children's Community Nursing team actually only operates on a Monday to Friday basis, but from April and next month it is, the intention or the expectation is that will become a 7-day service, which is a positive step going forward. In terms of SEND, I think I've highlighted this a number of times, but there is the 5-year programme of the Local Area Joint SEND Inspection, which is undertaken by Ofsted and Care Quality Commission. It's a 5-year programme that starts in 2016, so this is the final year of that programme. To date, Barnsley is one of only 33 local areas that are still to be inspected, so we are expecting that call for the inspection team to come and look at the local area. And it is a local area, as I keep saying, it's not just the local authority that's being inspected, it will be the input of the CCG into that. So we are expecting that to be fairly imminent. But to assure members, there's been a significant amount of work undertaken in that readiness for that inspection, but not really just for the inspection, because all the work that's being done is actually to improve the outcomes for the young people in Barnsley with SEND. So there is, as you would expect, there's a SEND improvement plan, an action plan. There's also a SEND strategy which is due for renew. So that work is being linked into from the CCG, both by myself and by our designated care officer for SEND. And we're ensuring that the CCG perspective, etc., and that the health input is brought within that. And the SEND improvement plan, the SEND strategy, I'm happy to share, but they are quite hefty documents. So I will only share it to those members who perhaps want to see that detail. And I'm happy to do that going forward. In terms of neurodevelopmental disorders, so for this, we're generally focusing on autism and ADHD. So as we've mentioned previously, there were issues 18 months ago in terms of the waiting list for certainly the over 11 autism pathway. Additional investment was put into that pathway, and we recommissioned it with BHNFT, and it's a very positive situation now in that all of our assessment and diagnostic care pathways for autism for children and people are all NICE compliant, and they're all now children seen from referral to end of the pathway within sort of 5 to 9 months, depending on which paediatrician that they are referred to initially. There are clearly some issues still. There's a lot of support needed for young people with autism, and our current focus seems to be on the assessment diagnostic pathway, not particularly on the pre and post support that's probably needed. So that's where the focus of the autism steering group is going to be, in what is it that we need for our young people to support them to become valued members of society, and so that they can deliver and live to their full potential, etc. So there's lots of work I think that we still need to do, and that will be done through the autism steering group, which I chair, and is a system-wide and multidisciplinary non-professional steering group. And also myself and Viv Williams from the CCG are leading on the development of an all-age autism strategy. So we're looking at and working with our comms team at how we can engage people with autism and with parent carers, etc., so that we ensure that their voice is centred to that strategy, and so that we end up with an action plan related to that strategy, which actually makes a difference, a positive difference to the lives of the people with autism and a neurodevelopmental disorder and within Barnsley. There is a pressure within the ADHD pathway, and which we're fully aware of in terms of the medication reviews, and there is work linking in with our clinical pharmacists to try to sort out how they can best be supported. That sort of initial support that was offered has not been uptaken because of the impact of COVID, and so we're looking at that, implementing or re-implementing that action plan so that our clinical pharmacists can provide that support going forward. In terms of the youth offending team, I recently presented a paper to the Youth Crime and Antisocial Behaviour Board to clarify and help to understand, so what is it that youth offending team are providing support in terms of physical health and mental health to our young people. As members are probably aware that the CCG fund 2 full-time CAMHS practitioners who are based solely within the youth offending team, so they can access that support. But as we also know that a significant amount of people who find themselves within this cohort have quite a certain level of either learning disability, or they have an element of speech, language and communication need, which we perhaps need to look at for how we can best support that going forward. And it's also interesting to note, I think, that the highest referrers into our children and young people substance misuse service are from the youth offending team. So I think there's lots of vulnerability in there, which perhaps need to focus a little bit more attention on, so that we can ensure that we provide the best support possible for that cohort of people. And then I've ended the report by looking at the sort of general joint commissioning element. Now, there is a children's services improvement plan, and it is quite a significant plan. And as you can see, some of the areas that that plan looks at, you can say that essentially the sort of local authority sort of statutory responsibility, but actually it is the responsibility of the whole system, I think. So it's just there to give you an indication of the huge amount of work that is being undertaken to support our young people. And once again, if members would like that detailed plan, I'm more than happy to share that as well. Obviously, I think we've heard from Jane and Joe about some of the complex healthcare needs and the learning disability service review in terms of Newsom Avenue and short breaks, etc. So that all links into sort of this children's improvement plan as well, and obviously provides a focus that we need to sort of continue to look at, particularly because not only are they escalating costs, but we need to look at with providing the right and the most appropriate provision for these young children within the community. I think I've probably said quite a bit there, so I shall leave that for any questions.
Thank you, Patrick. That's Ange Musgrave. She's helping me fix up my IT. It sounds like I'm giving her an order in a restaurant, doesn't it, Ange? So thank you for that detailed covering of this paper. Are there any questions for Patrick? I think one of the things is, Patrick, that we are really pleased with the improvements in the waiting list for CAMHS. So that's a very significant thing for Barnsley people. I think also the redirection of referrals seems to be appropriate. I don't know if others have had this experience, but I'm getting fewer people complaining over the past few months. Maybe that's because of COVID, but it seems there are fewer. And I think the other thing is, as that gets embedded, people have more confidence in the other services rather than saying, I haven't seen anyone or I haven't seen CAMHS. So I think it's good that the waiting list has improved. That's a really good step forward. Mike Sims, do you want to say anything?
Yeah, just to clarify, the waiting list is now the waiting list to treatment, not just the waiting list for the first appointment. Is that right? Because before we had this huge waiting list to be seen, and then they just moved it one step. So
yes, so the 66 young people are waiting at the end of January are waiting for their treatment to commence. So that they've had their initial assessment, and they've been assessed as being appropriate for one of the CAMHS pathways, and they're now waiting for that treatment to start.
So that's a major step forward.
Okay, so no other points. So thank you, Patrick. Thank you for that.
Thank you.
And we look forward to further updates in the future. Can we then move on to item 17, please? Richard, the risk and governance exception report, which has the assurance framework and the risk register. Thank you.
Yeah, thank you, Nick. So you've had the report, so I'll just focus on the key points. As far as the assurance framework is concerned, it's just there for governing bodies sort of information and assurance. It's continued to be reviewed and updated, but no significant changes this month compared with the last time that governing body saw it. As far as the risk register is concerned, governing body this time has the full risk register so that you can see everything that's on it, down to the sort of moderate and low risk items on there. There are 8 red risks on the risk register at the moment, which are listed out in the covering paper for you. And then there are just a number of updates which I'd like to bring to governing body's attention. The first is something that was alluded to under one of the papers earlier on in the meeting, which is that the risk relating to flu and the risk that we might have a flu epidemic overlay in the COVID pandemic, that risk score has been reduced from a 20 down to a 10 because we aren't seeing that prevalence of flu that we thought we might at one point. Then the next update is around 2 risks relating to COVID, the issues around hidden harm and the potential for sort of a demand surge as we work through our backlog. Again, those risks remain scored as red risks on the register, but the actual scores have been tweaked down by a few points in the light of a perceived slight reduction in those risks. The third update is around children's continuing care, and members of governing body will recall that we had a development session about this a few weeks ago, after which there was a request that we would put a risk on our risk register to reflect some of the issues and challenges that we're facing around children's continuing healthcare. That risk has now been developed by Joe Harrison and Jane and considered both at Quality and Patient Safety Committee and Finance and Performance Committee. And it's now included in the packet Appendix 2, just for governing body finally to approve that the addition of that risk onto the risk register. And then the last update on the risk register that I just wanted to pick up on was, again, something that was discussed under the Quality Highlights report, and it's the issues around D1s, and again the increase to the score around the D1 risk. Particularly in the light of the community pharmacy discharge service that we heard about before. So again, it was already a red risk, it remains a red risk, but the score has now been escalated up to a 20. So that was all I wanted to say on the risk register. As far as committee terms of reference are concerned, I'm just asking governing body to approve a relatively minor change to the terms of reference for the primary care commissioning committee. That's to do with the configuration of the groups that work on primary care issues beneath the committee, if you like. There's been some changes to those, and the establishment, for example, of a primary care strategic group. And so we're changing the terms of reference to reflect that. Members of that committee have already seen and sort of signalled that they're happy with that change. So I'm just asking governing body to formally approve that. Something that I don't actually pick up in the covering paper, but I did just want to mention for the minutes, is that we have also reviewed the remuneration committee terms of reference recently. And there's no proposal to make any changes to those terms of reference at the moment, but I did just want to note for the minutes that we've done that review. And then the final thing in my report is the governing body work plan, which comes to the governing body quarterly. This is really there just for your assurance that we have a plan of work which should, if we follow it through, will enable us to do all the things that we think we need to be doing as a governing body. That's there, as I say, for assurance, and also for anybody to shout up if they think that there's anything missing from there that should be on there, really. So that was all I was going to say. Nick, I'm happy to take any questions, or otherwise we can go through the ask.
Are there any questions or areas of clarification for Richard? If so, just put your hands up. Just can't see all the faces. Okay, I've got a couple of points, Richard.
Yeah.
And I think the first one is on page 7 of the risk register.
Yeah.
There is a risk for CCG 1410. If the Barnsley area is not able to attract and retain a suitable and sufficient primary care clinical workforce, the wording under that was before the long-term plan. So it was about practice resilience, sustainability, the PDA. That risk has been increased, and it's been increased on the back of the PCN DES additional roles. Yeah, and I think the two don't match together, because I think the risk around, although clinical workforce, the bits that come under that, PDA and other stuff, don't directly refer to additional roles. So I think we could just look at rewording either the additional risk or putting an extra risk around the delivery of the PCN DES and the additional roles, and what that will do, because the risks are less to practice stability. They are workforce risks, but they're less to the PDA or practice stability. They're more to what the current expectations and asks of us.
Yeah.
So I think that just needs a bit of a rethink in terms of, we've got one risk articulated, but a development that happened a couple of years later. We want to make sure that the risk score refers to the development, not to what was happening before. And there's obviously overlap, but I think we just need to, and maybe we have a chat with Julie Frampton about that.
Yeah, happy to do that.
The other bit, just to support what you said in terms of primary care commission, in terms of reference, the primary care strategic group, actually we had a very similar thing, and Chris Millington will remember when we set up the original primary care forum, which we said that would report to the primary care commissioning committee, but if there was something the commissioning committee was perhaps not entirely focused on or understood or unhappy with, rather than dismissing it out of hand and that being the end of the journey, they would give their feedback to that group, and that group would look at it again, take on board the feedback and resubmit. So it would make a recommendation, but also it could go both ways. So it wasn't a no, we're not doing that. It's, this is some of the feedback. Can you answer these questions for us? How will it fit with X, Y, Z? So I think that's the same principle that's in here. So that's not new. And those are the only comments I have. If nobody else has any comments, then I think you would probably better formally take us through the ask, if that's all right, Richard.
Yeah, that's fine. Thank you, Nick. So there were really two things that was asking governing body to approve, and that was the addition of the children's CHC risk to the risk register and the approve the changes to the PCC terms of reference. The rest of the ask is around noting the report, noting the assurance framework and risk register. I'm just finding my my report there. So yeah, so being assured that all risks are being appropriately managed, and also receiving and commenting on if you want to the work plan. So that's the risk. That's the ask, should I say, if we're happy with that.
Yep, we seem to be.
Okay, thank you very much.
So can we then move on to item 18, please? Integrated performance report, Roxana and Jamie. Roxana, do you want to do your bits first? Finance?
Yeah, thank you. So the report's there, it's been presented to the Finance and Performance Committee in detail last week. It notes that the CCG is on track to deliver financial balance. I did note in the minutes of the governing body, there was a note in there for me to provide a full update on the prescribing quit. And actually, I can confirm that the medicines management team will deliver the full 960k of efficiency that they set out to do in September. So that's on track to deliver. We do have some pressures coming through on prescribing, however, so the forecast is currently showing some pressure, but that's in relation to no cheaper stock and Cat-M drugs. The forecast also, as at month 10, shows 358 of the additional roles reimbursement relating to the PCN DES that we've referred to earlier in the meeting being utilised. An update to that position based on month 11 is that it's looking likely that 358k will not be utilised, and therefore we've notified the centre that will not be drawing down any of the £797,000 that is being held nationally in Barnsley. So that's just for the governing body to note that that's an update to the position that's reported here. I thought it was important that you were cited on that at this point. The COVID expenditure is just noted in the report for the governing body to know, and if there are any questions, but nothing's changed in that. There's been no new approvals. It's just the approvals that we had whilst we were in effectively gold command at the start of the pandemic. There's a small note in there as well around 21-22 planning. So this report was written a couple of weeks ago, and actually things have probably moved on slightly since then. So now we expect to receive a letter on or around the 25th of March. That's after NHS England board have met, and we expect to be in the financial framework to operate in two states. So you'll have H1, which will be Q1 and Q2, and that's effectively will be nationally modelled. Budgets and allocations will come through from the centre, and then H2, which I am assuming at that point will revert back to CCG allocations based on what we were notified of 3 years ago, but nothing has been confirmed yet. So we'll get formal communication on the 25th, and obviously the governing body will be updated at that point, and we have got a draft financial plan on the agenda in private to discuss later today. So that was all I wanted to update the governing body on in terms of the financial position.
Any questions for Roxana? Okay, thanks, Roxana. So Jamie, if you move on to the performance part of the report, please.
Well, yes, thank you. And hopefully people have had a chance to have a quick look at the report already. I think it is a familiar picture now, and unfortunately it continues to be a few more reds on the dashboard than we would hope and that we used to see before the pandemic started. But a couple of bits just to pull out on here, which I think are significant, and when we probably do an update on planning next time, we'll probably see that these areas are the focus in terms of addressing the impact of COVID. So if you look at the second paragraph under the performance update, I'm talking there around some of the constitutional standards around referral to treatment time and diagnostic weights. And I've pulled out specifically the increase around numbers of patients who are waiting over 52 weeks in there. So that's significant and will have continued to grow over the last couple of months as well. So as a sort of last January, that number would have been 0 patients waiting 52 weeks, and it's currently 562 patients waiting over 52 weeks. So that's significant. And the diagnostic position, so I've not included numbers in there, but I'll just give some by way of example, because diagnostic performance has always been very good in terms of like less than 1% of patients waiting 6 weeks since February 2020, or we've not achieved that since February 2020. So March, as soon as the pandemic hit, this worked through, and we've now got 2,315 people out of the 4,500 waiting for diagnostics having waited more than 6 weeks. So there's a couple of things in that. So January 2020, so a year before this data, there were 9. So from 9 waiting 6 weeks to 2,315 is huge, isn't it? But there were also 3,700 on the waiting list at that point for diagnostics. There's now 4,500. So people are waiting longer, and the waiting list is growing. And our plans and the expectation in the planning guidance that's come out is that we'll be putting a huge amount of focus into addressing that. The number's slightly less than it has been. So in September 2020, there were nearly 7,000 on the waiting list. So it has dropped back a little bit, but still is a challenge. So that's diagnostics. Urgent care continues to be a real challenge, particularly in A&E, mainly due to the space capacity. So in terms of activity, we have seen some of the activity coming back, and we've seen some increases on specific days, specific times. And when that happens, that leads to challenges in a department which is limited in space and having to cope with COVID position. It's still below the 1920 numbers, so looking at the sort of average attendances over this year compared to last year, it's around 70%, and it goes up and down depending on months. But when you map that against previous years' activity, it's probably now more akin to 17, 18 levels of activity. And governing body members who have been listening to these reports for the last couple of years will know that there's been a steady rise since that point. So back to that sort of level. And then the other area just to pull out is around cancer pathways, where, again, always reporting a strong position, and we continue to have some good performance in certain areas. But again, there are impacts for people who are waiting for cancer services. So 62-day referral to treatment. So overall, from receiving the referral to getting your cancer treatment, that has started to increase again, and it's mainly linked into diagnostics. So they're not huge numbers, these, but they're significant for the people who are waiting. So 72 people were treated in December, and of those, 24 had waited for more than 62 days for that treatment. So that's much bigger than we would have previously expected. And then the only other one I just picked up there, and we've touched on some mental health issues earlier, but this is IAP services, and it's actually a positive position, still slightly below, but actually as we've come out of the Christmas period, the number of referrals coming into IAPT have led to an increase in the access rate. There's probably still more work to do, and I think we've got a conversation in the private session this afternoon around that. On the other side of that coin, those people who are accessing the service are able to do so with fairly short waiting times, and the rate of recovery is also very good. So I think some positives, but we need to keep focused on making sure people can access that service. They're the key points I wanted to pull out. Thank you, Nick.
Thanks, Jamie. Any points anybody wishes to bring up or questions? Mike?
Yeah, I mean, at one point, I got the impression from the hospital that many of the long waits for investigations were the result of patient choice. In other words, patients were frightened to go to the hospital to have them done. I mean, is that still the situation, or has that changed? Has that moved on?
I think in the cancer ones, I think it's not that, Mike. But I think in the others there is a whole range of reasons, and some of the referrals through are still being quoted as patients, but I think there's such a backlog having to work back through and prioritise. Some of those who have chose to wait longer, we maybe not even worked back through yet to ask again whether it's they're still their intention to wait. So I think there's a mixed bag of reasons, really.
Right, thank you.
Any other points? I'd like to make a couple, Jamie. I think for the benefit of the public, the 562 people who are on more than 12 months wait, there is a ongoing review of those people and clinical prioritisation, so the most needy get done first, and that's ongoing.
Yes.
And that should work to minimise any harm from that unavoidable delay. The second one is in relation to diagnostics, and I think I brought this up somewhere the other day. What is useful to us as referrers into the system is that, as far as I can tell, for the first time recently, they've been putting on the expected waits for various tests. So if we're doing something which is perhaps not immediately urgent, and people expect to wait, we can share with them what the waiting time is for a routine investigation. And I think that helps them understand as well. And people seem to understand that were in this position. With regard to cancer referrals and things, I think as a GP, I'm not seeing any massive delays in anything, and certainly people being seen at the same time, and we're referring them through. So that provides a little bit, I think, of anecdotal. I mean, some of my GP colleagues may think differently, but I think to me, it feels a little reassuring anyway.
Yeah.
That we're doing what we can and managing that backlog in a sensible way and sharing it with the public.
Yeah, I think that's an important point, isn't it? The people who are waiting are not on a waiting list and not being cited. People are reviewing that waiting list on an ongoing basis and checking and bringing people and making sure that there is prioritisation in terms of how we reduce that. So those most at need will be treated sooner.
Okay, so if there are no other points on that, thanks Roxana, thank you Jamie. We move on to a series of committee reports and minutes. Section 19, so 19.1, unadopted minutes of the audit committee of the 21st of January. Nigel, they're unadopted. Do you wish to say anything?
Just a few things. We accepted the audit plan, external audit plan. We also looked at the NAO, National Audit Office checklist regarding financial reporting, and that was a very positive outcome, and that looked at the way we'd managed during COVID. We approved the CCG year-end accounting and governance timetable. We extended the external audit contract, and the last point on the escalation of items to governing body, mental health investment standard, has now been resolved. That was an issue about the actual terms of reference of that audit, and that's going to the audit committee next week for sign off, I believe. So that's all I had to say, unless anyone's got any questions.
Okay, thanks Nigel. Don't appear to be any questions. So 19.2 minutes of finance and performance of 7th of January and the 4th of Feb 2021, both been adopted. They're really here at this stage for information, unless there are any questions. Okay, so we move on to 19.3, assurance report, primary care commissioning committee, 28th of January, and that includes the minutes that have been adopted, as we would expect, from the 26th of November. Chris, anything you wish to share with us?
Thank you, Chair. I'll be brief. As you say, the report is here for assurance. Meeting on the 28th of January, as you say, primary care network has not achieved the full recruitment to the 60% allocation to the additional roles currently available as part of the primary care network DES. The underspend has resulted in the CCG being unable to draw down the additional 40% funding from NHS England to further the recruitment. At this point, I'd rely very much on Roxana to add any further details to that, should anyone need any more assurance. And as you quite rightly say, the November 20 meeting, which seems a long time ago, is here for assurance and is attached to the paper. Thank you.
Thank you. Chris, I have one minor point, and it's actually on the minutes of the 26th of November, and I fully accept they're adopted. But I think on page 7, Caxton House surgery closure, there's a lot of thanks to the primary care team for facilitating this, and I fully agree with those. But I think as a GP membership organisation, we should also express our thanks to the practices who took on these extra patients during a period of COVID pandemic, because they've had significant work to do, not just clinical, but administrative as well. So I think those thanks should be recorded. Apart from that.
Thank you for that, Chair. I have to say that I have raised that area of concern, and I know that those thanks have gone out to those people. I've actually seen it in writing somewhere. And I know it was a pressure, as John Harben, Dr. John Harben, has reminded me on a couple of occasions. But thank you for the people who did help us out on that. So thank you for putting that back on the table. Thank you.
Thank you. So if there are no further comments or questions, we'll move on to 19.4, which we've had the Quality and Patient Safety Committee highlight report. These are the minutes of the 17th of December. Madwi or Jane, anything additional you want to draw out from these that wasn't in the highlights report? They're just for information.
Yeah, nothing from me, Chair.
Okay.
Thank you.
Okay, thank you. And then we move 19.5, Quality and Engagement Committee Assurance Report, adopted minutes of the 3rd of December and 25th of Feb, which are yet to be adopted. Chris, anything you want to share with us or pick out from those?
Well, I'll just touch very briefly on 1 or 2 points, Chair, if you may. As you say, on the 25th of February, there's a lot of detail there, both in both of those reports, and this committee does have a very heavy agenda, and each and every time I compliment the secretarial work that's put into this, because the amount of capture that we managed to do is quite fantastic. We did discuss in some detail the effects of the COVID virus and how it's impacting our local communities. The Health Watch report, which our head of communication went through earlier, shows the vast amount of data now collected. The comment, which I agreed on at the time, was don't waste this important information, which came through our chief nurse and which I've already earlier in the meeting commented on. We reviewed the people and organisational development strategy 2021 through to 2022. As you noted, the minutes from our December 2020 meeting are here also for further assurance. Those have now been adopted, so happy to take any questions.
Any questions? No? Okay, thank you for that, Chris. We move on to 19.6, which are the minutes of the Health and Wellbeing Board of the 4th of Feb. Happy to take any questions. You've all read them. Okay, so thank you for that. So we move on to the reports that were circulated in advance. And unless there's anything on any of those, we'll move straight on to 21, which will be a reflection on how well the meeting's business has been conducted. I must say, I had some IT problems earlier, and it is really frustrating. So now that I know I can do this meeting in Andrew's room, it shouldn't happen again. But it is really frustrating when you've prepared, and sometimes when you can listen to a conversation and you can't contribute. So anyway, we got to a better place with IT about halfway through. I'd like to thank Chris for taking over the chairing of that in my absence. Thank you, Chris. And I'd like to thank Kay and the governing body members and the Barnsley public for supporting and helping us with this meeting. Thank you. At this point, I would ask the governing body if we could move to the private session, and if they